Hi, I'm Bipin Mathew. I'm a consultant dermatopathologist. I work at Leeds teaching hospitals. On the melanoma side, I run the National Melanoma Slide Club, and I also provide expert opinion on difficult cases of melanocytic tumors. In the past few years, I've also been developing the genomic panel for testing of melanocytic tumors with NHS England, so it's all good news out there. I'm sure many of you know that pathology labs are critical and often unseen element of modern medicine, although they play perhaps a very important role in diagnosis. And not just diagnosis, we play a role in monitoring patients and also informing treatment of patients. Now, in the UK and in Western countries, pathology underpins 70% of all diagnoses. But do you know what happens from when a surgeon or dermatologist takes your sample and what's done till you get a final report? So let's take a closer look at how melanomas are diagnosed. And I'm fully aware that navigating a melanoma diagnosis for many of you is really overwhelming. When you're told you have a melanoma, all the stress, and then suddenly you have all these difficult terminologies and jargon that you need to comprehend to understand what the tumor is like. Yeah. So today my mission is to do a deep dive to try and demystify the entire process of melanoma diagnosis, step by step, from when you notice a concerning spot on your skin, right through the dermatology or GP clinic, and then we follow the tissue through the pathology lab till you get that diagnostic report. So the core theme of my presentation is that early and accurate diagnosis is more important than anything else in the world of melanoma. So the earlier you get it, the better for the patient. And through this, I also want to empower you to understand how the diagnostic process works, what the delay in results mean, because sometimes results can take a few weeks, sometimes even a few months. So this is purely my opinion that there is a myth, probably worldwide, that it's the pathologist that makes the diagnosis, and hopefully by the end of this lecture, I'm going to try and flip that coin, because I believe diagnosis is a team-based effort, and it's akin to a team doing a jigsaw puzzle with specific pieces for each member of that team. Or think of it like a 4 into 100 times relay, with you being the starting person and the pathologist being the anchor of the relay team. So by being a team, we can detect lesions early, and we all know that if we detect lesions early, you have a 98% 5-year survival rate, whereas if the tumor melanoma spreads, the survival rate dips down to 30%. So let's start at the very beginning of this timeline. So we know that if a patient has fair skin, red or blonde hair, history of severe blistering in childhood, strong family history, their statistical risk of developing melanoma is very significant. But the fundamental truth is that anybody can develop melanoma. And in fact, there is a misconception that only fair-skinned patients can develop, fair-skinned individuals can develop melanoma, but people of all ethnicities can develop melanoma. And I think we need to address that misconception as well, because in those patients, melanoma can be underdetected, and often when detected, it's already spread. So in these individuals, melanoma can occur on the palm, on the feet, under the nail bed, locations that we not normally look at. So the diagnostic journey, at least in my experience, is when patients are self-examining themselves, often in front of a bathroom mirror, or when a partner points at an odd spot on the back. And that is when the journey begins. So And oftentimes, patients ideally should examine themselves in a well-lit room, maybe with a hand mirror to look at areas that they normally wouldn't see when facing a mirror. So, yes, looking for a mole or a particular worrying spot is important, but it's also important to know what to look for. And that is where we've come up with the ABCD criteria, which we saw on the screen earlier on. So A is for asymmetry. We know that melanoma does not grow in a coordinated manner like a benign mole. So it grows in a lopsided manner. So part of the mole can be elevated and bigger, and part of the mole can be flat. We know that melanoma does not define normal anatomical territories. So when it grows, the borders are very ill-defined. We know that melanoma, unlike a benign mole, so benign moles can be dark-colored, but melanoma can be dark-colored or varyingly colored. And these colors mean a lot. For example, if a melanoma is red-colored in areas, you can assume that there is inflammation that's attacking the melanoma. Or when you're looking at a mole, if you see white streaks, you know that perhaps the immune system has destroyed the melanoma and just left a scar there. Diameter of the lesion is also important. For many years, we believed lesions more than 6 millimeter should be concerning. So 6 millimeter is basically the same size as a pencil eraser, but now we are detecting melanoma that are less than 6 millimeter. So just relying on 6 millimeter rule, we may miss melanoma. Now, if nothing, the most important of these is E. So E stands for evolution, and this is the ultimate red flag. So a benign mole will look the same month to month, year on year. So there's no noticeable change in size, shape, color, elevation. But when a mole starts growing rapidly, or it changes from flat to being raised, or it begins to itch, or it begins to bleed without any preceding trauma, this is evolution. So if you, on self-examination, you have a visceral sense that a mole has changed, you must trust that instinct. You must go to a doctor immediately, because you are the best judge of that mole. So in addition to ABCD, there's this concept of ugly duckling sign. And as humans, we are naturally born with pattern recognition to spot the odd one out. In fact, a lot of the games that we play is to do with pattern recognition, spotting the odd one out. So for patients who have multiple melanocytic lesions, you treat these melanocytic lesions as a flock. And if you find the odd one in the flock, that's the one that needs to be seen by an expert. So when you've spotted a worrying spot, you want to consult a dermatologist. And dermatologists, of course, apply the ABCD criteria, but they also have a new tool called the dermatoscope, which enhances the diagnosis significantly. And so imagine a lake, and when you have light reflecting on the lake, you cannot see what's under the lake. You can't see the fish swimming around. But what a dermatoscope does is it mitigates that. So you have the special kind of light that is shined on skin, and that light can pass through the surface layers of the skin, and a dermatologist can then study the pattern within a mole. So nowadays, you can attach a camera to that dermatoscope, and you can take pictures, and then when the patient comes a few months later, you again take pictures, and you look at whether the mole has changed. In addition, a few centers in the UK are now doing total digital photography, where patients with multiple moles have photography in different poses, and they have that baseline photographs. And eventually, every few months, when they come back and those photographs are taken, these photographs are then evaluated by AI and machine learning tools to identify, again, the mole that has changed, the ugly duckling. There are other new technologies that are on the pipeline. So there is a technology called reflective confocal microscopy, where the dermatologists, when you're sat next to them, they again shine this near infrared light, and that reflection is captured, and the computer then comes up with an image where the dermatologist can actually see the superficial portion of the lesion in microscopic detail, and they can then kind of come to conclusions whether a mole is worrying or not worrying. Also, the new kid on the block is an adhesive patch test, where they put a sticky patch on the skin, they remove the patch, and from that patch, they harvest DNA and RNA, and then that DNA and RNA is then sequenced, and they are looking for proteins like PRAME, which Dr. Wu highlighted. So they are looking for proteins that are increasingly expressed in melanoma, like PRAME, and if PRAME is detected, then of course that melanocytic lesion is of concern. So if all these tests that we do, if it raises concern for melanoma, the physical tissue must be removed and then examined under a microscope. And this is a massive pivot point for the patient's journey. So before we see a lesion under the microscope, the lesion has to be removed. And the biopsy is the gold standard as it stands, but that will change, I suspect, over the next few decades. There are many different types of biopsies, as you know. Clinicians do punch biopsies, which is like a round cookie cutter. In rotating motions, they go through the lesion, and with tweezers, they pull out a cylindrical piece of tissue. Then some clinicians do a shaved biopsy, where you have a double-edged blade. It's also called a saucerization biopsy, where you remove the superficial part of the lesion, but the deep portion of the lesion still remains. But the best sample for examination is actually an excision biopsy, where a dermatologist or surgeon removes the lesion and normal tissue around the lesion, at least a 2 millimeter margin around the lesion, so that the pathologist can examine the entirety of the lesion. Do bear in mind that one of the worries patients sometimes have is that the surgeon says, I've removed a 2 millimeter or 5 millimeter margin around the lesion. But the moment you remove tissue from outside the body, the tissue shrinks. So that 2 millimeter margin becomes 1 millimeter margin. So if a pathologist says the tumor is 1 millimeter clear, it's just because of that shrinkage. There are other causes of shrinkage, which I'll come to over the next few slides. Now, although I say excision biopsy is the gold standard, and that is what you will request as an empowered patient, you'll request of your clinician, sometimes when lesions are in cosmetically sensitive sites like the nose, the cheek, where you have a big lesion, before removing the lesion, before doing heavy plastic surgery, sometimes dermatologists do punch biopsies to make a diagnosis and also to map the lesion. But outside that context, excision is the best sample. So now the biopsy is taken, and the dermatologist or surgeon, they put the biopsy in this chemical called formalin. And what formalin does is 10% formalin, it preserves the cells in the state it was removed. So it prevents degrading of the cells so that those cells can be studied under the microscope. Now, oftentimes in NHS hospitals, the biopsy is taken in one hospital, the pathology lab is another hospital, and transport times can vary. Sometimes transport time is within a day, sometimes it's 3 days. And sometimes if a biopsy is taken on a Friday, it reaches the pathology lab on a Monday. So that's when the pathologist first gets to look at the sample. And then the biopsy undergoes a multi-step physical transformation. So if you actually map the processes, the biopsy goes through over 117 steps. And at each step, the pathology lab has to ensure that it's Mr. Smith's sample that is going through all those 117 processes. So once it's submerged in formalin, once it reaches the the pathology lab, a pathologist looks at it, and the pathologist starts cutting it into smaller pieces. So these slices are 3 to 4 millimeter thick. They study the lesion again using the ABCD criteria, and areas that they are worried, they may do extra levels on it. So once those sections are taken, those slices are taken, they go through processing where the tissue goes through a series of alcohols where we are basically dehydrating the tissue, and then we embed the tissue in molten wax, a small block of molten wax, so that we are creating a consistency for the tissue that the tissue can be cut with a very sharp knife. And that knife is called a microtome. And to handle this microtome, you have a very senior biomedical scientist, and what they do is they cut 4-micron sections. So imagine your hair, that's 70 microns on average. So our scientists, they cut 4 microns so that that 4-micron slice can be put on a slide, and it's a translucent section, so light can pass through it, and therefore somebody can study it under the microscope. Now, I'd like to point out that imagine a patient, they have a 6-millimeter lesion, and I make 2 slices of it, 3 millimeter in one slice, 3 millimeter in the other slice, yeah? So when I'm studying the lesion under the microscope, I'm studying only 4 microns of that 3 millimeter. So 3 millimeter is 3,000 microns, yeah? I will not be able to study all the 3,000 microns because that would be resource intense. The NHS cannot afford it. So that is where the history that you provide, where you've told the clinician, hey, this is what's happened, the lesion's changed. So based on that, I decide how much of the tissue to study. Yeah? So it's very, very important that you communicate everything you know about the case, about the lesion, to the dermatologist. So when I'm looking at a case under the microscope, I straight away don't look at the slide. I look at what the patient said to the clinician. So I look at the clinical notes. I look at the images. And then I decide to look at the slides. Yeah? So again, I have to stress that if somebody asks me, which is the most important bit of the diagnostic pathway, it's you. It's what you've told the dermatologist, because that guides me on what to do next with the specimen, yeah? So when I start looking at the slide, I decide, is it a melanocytic tumor, or there are millions of lesions that can mimic melanocytic tumors? There's the other side of the coin as well. Melanocytic tumors are masters of disguise. They can look like basal cell carcinoma. They can look like, other lesions, like a seborrheic keratosis, and so on. And there are many families of melanocytic lesions, because often patients think that a melanocytic tumor is black and white. You have a benign mole, you have a melanoma, but that's not the case. So melanocytic lesions are a spectrum. So you have benign at one end, malignant at the other end, and in the middle, you have lesions called melanocytoma, yeah? So as a pathologist, my time is taken to try and distinguish, is it benign, is it melanocytoma, or is it melanoma? So basically, I'm trying to tease apart the wolf in sheep's clothing from the sheep in wolf's clothing, yeah? So that's my job. That's what pays my mortgage. So approximately 50% of the lesions are straightforward, absolutely straightforward. I know in 5 minutes it's benign or malignant. But around 30 to 40% of the lesions, I may have to do additional tests. So additional tests means additional time in your patient journey. So I request levels, I may request immunohistochemistry, and I may request genetic studies. And then there are around 5 to 10% of the cases where I just write in my report, I really, really don't know. I've done everything I could possibly do. I really, really don't know whether it's benign or malignant. Of course, at the present time, we treat these in the worst case scenario, like these are melanoma. Yeah? So this is what I see. So this is a hematoxylin and eosin section. Hematoxylin and eosin are dyes that I use to color the cells, where the nucleus takes a blue color due to hematoxylin, and the cytoplasm takes a pink color because of eosin. So that's the first step in the pathway. Then I study the section, and basically what I'm looking for is chaos. So if I see chaos, the more chaos I see, it's going towards melanoma. The more coordinated growth I see, I'm going towards a benign mole. Sometimes I have to do immunohistochemistry to make the distinction between benign and malignant. For example, I may do so what is immunohistochemistry? So these are antibodies that I target, through which I target proteins on the melanoma cell, and with that, I can conclude whether a tumor is melanoma or whether a tumor maybe is a carcinoma. So this section here shows a PRAME stain, and you can see the brown staining in all the tumor cells, and so that indicates that this is probably a melanoma. The other bit I do is genomic testing, and we know that the DNA, there are 4 billion letters in every cell of the body, and around 10% or 1% of that code for genes. And of course, to get a tumor, you need genes that are switched on and some good genes that are switched off. So benign moles also show mutations, whereas melanoma show mutations in multiple genes. Yeah. So eventually, I produced this report, and that is where I provide a verdict. So I summarize whatever I am seeing based on whatever clinical information is provided to me, and I come up with a final report. So there are some important parameters in my report that I'm sure many of you would have seen and some of you would understand. So the most important of this is Breslow thickness, where I measure the thickness in millimeter using an ocular micrometer of the tumor from the surface to the deepest invasive cell. Now, why is it important? The Breslow thickness directly correlates with the tumor's access to the body's highway systems. So if a melanoma is confined to the superficial layers of the skin, that is Breslow 0, it cannot spread. Whereas if the tumor becomes thicker, it has access to all these highways. It's a bit like living in Leeds, where the M1 and M62 intersect, really. So it can easily slip into the pummeling of the organ and spread to lymph nodes or lungs or brain. So Breslow thickness is very, very powerful. The other bit you may see is radial growth phase or vertical growth phase. And the way I imagine it is, think of a bucket of water that you spill on the floor. And initially you see the water going sideways, and that's radial growth phase. But eventually you see the water going through the floorboards and more of the water getting into the floorboards, and that's vertical growth phase. So that's melanoma that's going through, perforating, penetrating through your tissue, and again, getting into those highways. The other important bit is ulceration. So the presence of or absence of ulceration is important. And ulceration is, again, diagnosed microscopically, where the tumor grows so quickly that it destroys the roof of the house it's growing in. So that's ulceration. And the final bit is mitotic count. Now, if you did biology in GCSEs, you know that cells divide. And when cells divide, they form a structure called a mitotic figure. So as a pathologist, I count the number of mitotic figures per high-power field, and that also bears a relation to prognosis. And finally, in my report, the other important parameter I say is the tumor excised, or it's not excised, whether it's at the margin where the surgeon cut it or not. So just quickly about the human element of medical diagnosis. Many patients feel pathology is black and white, but it is not true. It is an interpretative opinion. So as the information changes, the interpretation can change. Yeah? So it's a bit like a treasure hunt. As you give me more data, my information can change, which is why it's good to have all the data with me in the first place. Yeah? So interestingly, they grouped together 18 of the world's top dermatopathologists. They showed them around a few hundred lesions, and they found that their agreement without the clinical information is equivalent to a flip of a coin. You could actually flip a coin. Yeah. So there are many studies that have shown that. However, histology is still the gold standard, and I know that this ambiguity for the patient waiting at home for the phone to ring, it's terrible. Yeah? And because of this ambiguity, there are two types of errors. There's underdiagnosis, where A malignant mole is called benign, which is terrible. But I feel even overdiagnosis is terrible, where the patient gets scarring because of surgery, they get unnecessary surveillance, unnecessary procedures, they then become a cancer survivor, higher insurance, and so on. So at some point, we need to square the circle. My only tip with this slide is, if you get a report where you are told by your doctor that the lesion is ambiguous, immediately please seek a second opinion. It's good for an expert or another expert, 3 people to look at it so that, one can make a more conclusive diagnosis. So please do not hesitate to take a second opinion. So the other bit of pathology is beyond the diagnosis of melanoma, where the surgeon removes a sentinel lymph node. And to understand what a sentinel lymph node is you have to visualize the lymphatic system. These are like rivers flowing through the body that carries the immune fluid. And these lymph nodes are kind of dams that filter this immune fluid. They filter even things like tattoo pigment, foreign material, bacteria, and so on. So in this slide, I can point out that here on the left side is a sentinel lymph node. Now, sentinel lymph node can have benign nevi as well, and sentinel nevi can have metastatic melanoma as well. So that's another challenge that I have to say, is it melanoma in the node, or is it a benign nevus in the node? So you can have nevi in the node. So here's another section, hematoxyliosin section, where you have nevus in the capsule, and then under the capsule, you have metastatic melanoma. And I have used immunohistochemistry to identify that as well in the slide in the right side. Here's another slide where the melanoma here is in a lymphatic channel in one of the rivers. It still hasn't reached the lymph node, so I captured it in the fat that was surrounding the lymph node. It hadn't yet reached. And here's another slide where it's reached near the capsule of the lymph node, but has not gone into the lymph node. So all of this, the breast load, the ulceration, and the lymph node status leads to the final stage. And we know that staging is what determines further management. So the closing slides is that I'm hoping that you all will be co-pilots for your treatment. So I'm not the only pilot, there are multiple pilots, and together we can take the plane to the right destination. Of course, if you're not flying via the Middle East. So you play a pivotal role in the diagnostic pathway. So knowing your skin, practicing self-examination is very, very important. Using dermoscopy improves the diagnosis, but biopsy is always needed for confirmation. So the pathology report is your roadmap. You know a few of the criteria and why it's important. And of course, now you know that diagnosis can be challenging. There is inter-observer variation, and seek an expert opinion if you get an ambiguous diagnosis. So not all is bleak. Now think of a few hundred years back where, we didn't know what a melanoma was till somebody said, oh, this is a melanoma. And then people started looking at these lesions clinically. Then, of course, ABCD criteria was invented. Then dermoscopy was invented. Then you have now reflectance confocal microscopy. You have all this genomic testing. And I believe that in 10 to 15 years, I may not have a job because, with liquid biopsies, you can potentially take blood from a patient with a worrying melanocytic tumor. You can actually sample their DNA. You can look at the gene expression profile. And then, of course, Dr. Wu will understand, whether, looking at the gene signature of the melanoma, whether his patients will respond to immunotherapy or not. So he'll be able to easily capture those 40% of the patients that will respond to immunotherapy and perhaps not give immunotherapy to the 50 to 60% who may not respond but are still having the side effects. So that's the end of my talk. And sorry for hurrying. Yeah.
Thank you, Bipin.